My name is Peter McCullough, and I'm an internist and cardiologist from Baylor University Medical Center in Dallas, Texas. And it's an absolute pleasure to chair this symposium concerning lipoprotein-associated phospholipase A2 with two terrific faculty, which I'll introduce in turn when they come up. So our title of our topic tonight is the new lipoprotein-associated phospholipase A2 activity test for coronary heart disease risk assessment. And our objectives are to understand LPPLA2 and its role in pathophysiology, discuss the new Mayo Clinic data on analytic performance, go over clinical utility data from a large multi-center NIH cohort, and we're very lucky to have Mary Cushman here from the University of Vermont, who heads up that big NIH initiative. And then we'll get into the analytic performance of the plaque activity test. And even though most of you are not in the laboratory, it's important for you to understand these nuances of the laboratory methodology from the old test to the new test, because it matters in clinical practice. And then we'll talk about appropriate use and integration of the test into the laboratory. So those are our program objectives. And then here are our faculty. And I think what we'll do is we'll just kind of introduce each person as we get going in the program. Now, there is on your seat, there is a little flyer about the information portal. So you'll see this lady here who looks like she's really tired at the end of a conference, but she's ready for information if she goes to the portal. And it's a clinical knowledge portal that gives information regarding coronary heart disease risk assessment and certainly the biomarker lipoprotein-associated phospholipase A2. So with that, I'll get started, I guess, just by a brief word of introduction. As I said, I'm an internist and cardiologist, and I started down in Texas. I went to Baylor undergraduate and UT Southwestern, and then moved on to the University of Washington in Seattle. So I guess I'm a Washington Husky in part. And then I had a period of time where I signed up for rural health and did rural health service in northern Michigan. So I worked as a real primary care doctor before coming down to the University of Michigan in Ann Arbor, and I studied in epidemiology and statistics, and then served my fellowship under Bill O'Neill at William Beaumont Hospital in Royal Oak, Michigan, which at the time I think still is our nation's busiest hospital and biggest cardiovascular center. And then I had several leadership roles in Michigan. I had just a brief stint where I was chief of cardiology at University of Missouri, but largely in Michigan until the final chapter of my career, when I had a chance to move down to Texas and rejoin colleagues at Baylor. Mike Emmett, who's the chief of medicine. I serve as a vice chief of medicine under Mike Emmett, and I lead cardiovascular education and research. For those of you who may remember Clyde Yancey, who leads cardiology at Northwestern now, I basically took Clyde's old job. They were nice enough to keep it open for me. And so I have a chance to office with Dr. Bill Roberts, who's the editor of the American Journal of Cardiology. And I tell you, it's a real professional highlight to be with Dr. Roberts every day at Baylor. So having said that, I will jump into my talk, LPPLA2, an advanced biomarker for coronary heart disease risk. And the points that I wanted to make, and we've published a lot on this, is that there really are 4 reasons to order a test. And those reasons include screening, diagnosis, prognosis, and management. Those are the 4 legitimate reasons to order a test. In fact, they're reimbursable reasons, the reasons why the FDA approves tests. And one of the things I've heard on rounds is that the only reason to order a test is to change management. That's actually incorrect. In fact, that is pretty myopic when you look at the other activities that we do with tests every day that improve medicine. It's been studied, the laboratory provides information in clinical medicine that's of the highest yield and the lowest cost of all different areas of medicine. So it's actually the biggest value that we have. It's been estimated that the lab is responsible for about 70% of diagnoses. 70%. So you can imagine where we'd be without the clinical laboratory. So about 70% of diagnoses, and honestly probably about 80 to 90% of actionable issues in patients are in part, if not exclusively, laboratory based. So as a medical cardiologist and internist, I'm a big believer that one of our chores is to really be experts in the clinical use of the laboratory. So I'll follow this outline and just make a few points. I have a short talk, but I certainly want to clue in the group with respect to lifetime cardiovascular risk on the positive side. And I always point to this paper in New England Journal of Medicine a few years ago about lifetime risk, simply to make the point that in men and women with 2 or more risk factors, and many of us fall in that category, I know I do, that with 2 risk factors, I run the chances over the course of my life of maybe a 40 or 50% lifetime risk of a non-fatal myocardial infarction or cardiovascular death. However, if my risk factors are perfectly managed over the course of my life, that risk can be managed down, at least epidemiologically, can be managed down to about 10%. Hopefully less than 5%. So I've always said that I personally never plan to have a myocardial infarction. I never plan to undergo a heart catheterization. In fact, I want to manage myself away from that by managing risk. And it's really stunning what's happened. Preventive cardiology has had so many wins over the last 20 years. Bypass surgery in the United States is down by 80% over the last 20 years. Coronary angioplasty just hit the 50% reduction mark. At our peak, we are at 950,000 PCIs, and I think last year I saw just shy of 500,000. It really is stunning the advancements that we've had in preventive cardiology, and it's because management of risk factors really does work. And so with that, there's always been a debate in preventive cardiology. Can laboratory tools, something beyond the conventional tests that we order, can they really offer us something in a tool in a toolbox? And that's where lipoprotein-associated phospholipase A2 comes in. Most of you who are members of the National Lipid Association or American Society of Preventive Cardiology use this test and are familiar with the idea that Lp(a)2 cleaves products that contribute to vascular inflammation. And the idea here is that we have LDL, that in fact Lp(a)2, which rides in part on LDL, cleaves lipids into lysophosphadylcholine and oxidized free fatty acids, and that these themselves contribute to the progression in atherosclerosis and may in fact promote instability of plaque and further activate potentially enzymes that break down collagen and the fibrous plaque. And that was suggested in this paper, and there's many more like this, and just to kind of clue you in. So these are anatomic specimens of patients with fatal MI, and looking at various lesions up and down the coronary tree. This is just intimal thickening. This is a fibroatheroma. This is a thin-capped fibroatheroma plaque, and this is a plaque that's ruptured, and you can see a graded increase in the staining for Lp(a)2. So it's been said that outside of LDL cholesterol or just cholesterol itself, that the only other real pathogenic factor that we can measure in blood that's at the scene of the crime of a ruptured plaque is Lp(a)2. You can't find the same data for CRP or even for myeloperoxidase or some of the other advanced measures. So Lp(a)2, in my view, and the products of its enzymatic activity may play an explained role in promoting plaque progression, vulnerability, instability. And so it's really been our task to try to explore this from a laboratory and therapeutic perspective. Where does Lp(a)2 come from? Well, circulating macrophages produce it, and then it does attach to LDL on the ApoB particle, but some of it is free. Some of it also rides on other lipid particles. It does get ingress into the subendothelial space, and as shown in the last slide, it's physically there, and it's participating in enzymatic activity and degradation of lipid material, particularly phosphatidylcholine and oxidized fatty acids. And it's thought that those fuel some of the progression that we see in atherosclerosis. There have been studies using MRI technology to actually physically in the body see where it is. Now, this is in healthy, in this case, healthy individuals. These are actually animals where in induced atheroma in the aorta, one can actually physically see the enzyme here. This is conventional contrast. This is a patient with no atherosclerosis. So, in fact, one can see that it's physically produced in plaque. But besides that, the other pool of macrophages are the liver, the spleen, in general, the vasculature. There's even been studies where the coronary sinus has been intubated, and we've actually had a measurement of inflow and outflow of the human heart. And in the setting of atherosclerosis, as you can see here, there's a net output, a production of LPA2 from the coronary vascular tree in the setting of atherosclerosis compared to without individuals without atherosclerosis. And that's not like CRP. CRP is not really produced in any way by atherosclerotic plaque, but in fact, these data and others suggest that LPA2 is actually a product of atherosclerosis. Well, there's two ways to measure it. Those of you who use this in your practice, and I know I've used this test, I think, for over 10 years now, have used the ELISA method, or the enzyme-linked immunosorbent assay, and that's in plasma or serum where there are two monoclonal antibodies, a capture antibody and a detection antibody, and fluorescence. Dr. Blick's going to explain a lot more about this. This is our conventional way of measuring a concentration. It's been called the mass assay. It's probably a misnomer. It's really just the concentration of the protein. The other method, and the new method that's just become available, is the enzyme activity, where then patients' a blood sample is provided to a substrate, and we actually look at the amount of conversion of a synthetic substrate and the activity of the enzyme. So the determinants of the activity of the enzyme are in part the concentration, but in part many other things that enable the activity of the assay, including how much is bound, how much is free, how much is actually exposed to substrate, potentially polymorphisms in the activity of the enzyme. And so the activity assay, while it correlates with the concentration, it's certainly not a tight correlation, and in fact gives us a new angle to look at atherosclerosis. So what is the clinical impact here? I had a chance to work with Peter Toth and others a few years ago. Mike Wagner, who's a really terrific guy who's been in industry a long time, and we had a chance to summarize the major epidemiologic studies with LPA2 measured in concentration. And what this table really highlights is the fact in patients post-MI, patients with stable coronary heart disease in the office, and even in patients at risk for stroke, this test is consistently across epidemiologic studies, been both internally and externally consistent and independently associated with cardiovascular events. I was particularly impressed when we did this review. I was particularly impressed with this paper from the ERIC study. Remember, ERIC's one of the modern day NIH-funded epidemiologic studies, the atherosclerosis and community at risk study in young individuals, okay, followed over time. And this analysis looked at patients who had incident stroke. And you can see here that the baseline LPA2 and the baseline CRP both were predictive of stroke. And in fact, patients that were in the top tertile of CRP and the top tertile of LPA2, those individuals actually had the highest overall risk ratios. And in epidemiology, we hardly ever see risk ratios of 11. I mean, standard cardiovascular risk factors, it's about 2. And I think this is a particularly important paper suggesting that vascular inflammation, or maybe that's a bad term, cell signaling or enzymatic activation in the case of LPA2 is really part and parcel of destabilization of plaques and the risk of stroke. It was actually this study and others that won this test the FDA clearance or indication for risk prediction in stroke. And to this day, it's the only test that is actually available for risk prediction in a stroke. Not even LDL cholesterol, CRP, or other tests actually have that indication. Now, people have asked, okay, this rides on LDL. What really is the relationship? There is a correlation, but it's not very strong. It's pretty much a scatter plot because it rides on other lipid particles and also exists to some degree free in the plasma as it's produced, as it's secreted by macrophages. As I've shown you, anatomically, it's resident in tissues, and there's an efflux of LPA2 out of plaque into the bloodstream, as we saw in the coronary arteries. So one of the theories that we've had out there is that if we could actually reduce LPA2, also known as the plaque assay test, if we could reduce the concentration or now even the activity, could we actually have a reduction in risk? And so this is unlike some other factors in the bloodstream. This is modifiable. In fact, this test is responsive to the therapies that we can use in atherosclerosis, in the treatment of atherosclerosis. Now, here's some recent data with the activity assay just showing how responsive it is. This is the relative risk per standard deviation unit. So not even a tertile or a quartile, but actually a standard deviation unit. So it's very responsive. This is a well-done prospective cohort study, and every multivariate adjustment possible that this test independently anticipates future cardiovascular events, non-fatal MI and cardiovascular death, and it was very cardiovascular specific. So here's incident cardiovascular disease by tertile. Here's non-cardiovascular death and cardiovascular death. And for the non-cardiovascular death, it could not separate the groups, but in fact does so for the cardiovascular events. And so this is one of the few tests that we have as an advanced risk marker in cardiovascular epidemiology that I think has really stood the test of time. It's really been exhaustively studied in cohort studies, some of the best cohort studies available, and in fact is very much cardiac specific. But many have been interested in the drugs that can reduce levels of Lp(a)2. Which drugs can do it? Just in terms of pictogram, I'm not going to go through all the trials. Statins do lower Lp(a)2, no doubt about it. And they lower it in somewhat of an independent fashion from LDL. It's not a one-to-one reduction. But also niacin lowers it to some degree. Fibrates lower it to some degree. Omega-3 fatty acids, one of the few kind of lipid-related measures that really does move in a favorable direction with omega-3 fatty acids. Recent paper, anti-PCSK9 monoclonal antibodies. Doesn't drop as far as LDL does, but in general reduces by about 30%. Ezetimibe. And then the big discussion point in preventive cardiology a few years ago was daraplatib, and then a somewhat related entity called varisplatib. And here, these entities were specific inhibitors of Lp(a)2 that actually dropped a form of an activity assay down, but did not influence atherosclerosis in terms of binary events. And to this day, it's still a mystery of how this enzyme, its activity could be reduced in plasma and have it not influence atherosclerotic events. And there's been many explanations that maybe it simply isn't working at the site of the plaque, or in fact the substrate, or the way that this interferes with the enzyme and the substrate is just simply not in the, in a sense, set up biologically as a potential the appropriate therapeutic target in atherosclerosis. But having said that, the test seems to work very well as a diagnostic test. It's simply not what we call a theragnostic. That is, it's not something that a therapy directly is going to be applied against. I've always thought this, out of all the papers with measuring the plaque assay, I thought this was one of the more powerful ones. This is from the Mayo Clinic. These are patients in Olmsted County who had acute MI, 271 patients who had the plaque test measured at about the time of the acute MI, and they were organized into these tertiles. And you can see here, under the plaque concentration assay, those who had less than a 166, those individuals had nearly a perfect survival out to a year, with really a dramatic difference, about a 15% mortality, in those who had a much higher value. And so one of the things you'll see in the data is this test offers some hope that we could actually get to some treatment target, that if we could actually bring it down to a sufficiently low level, we may, with the multi-drug environment that we have to treat atherosclerosis, we may be able to get down to a zero event type of situation. And so I've used it in my practice for about 10 years, and I understand the caveats of all of this. I still think it's useful. Today at Baylor, I just been kind of racing around the country. Today at Baylor, we had a lady, a nice lady, a few years older than me, who had diabetes, and she had rheumatoid arthritis, and she presented with a non-ST segment elevation myocardial infarction, a pretty big one. She had multivessel disease. Her LDL was 117. She was not on aspirin and not on a statin. She goes, hey, I never saw a cardiologist before. I saw my primary care doctor. And she's the type of person where the LDL doesn't scream atherosclerosis. I mean, a lot of you would say, oh, she should be on treatment because she's a diabetic, and I'd agree with you. But there's a lot of patients out there in primary care with LDLs of 117 that aren't touched with preventive therapy, that in fact, I think additional testing would help make it more readily understandable that atherosclerosis is around the corner. She suffered a big infarct, and we're really having to work on her. In this study, the LDL in this case was 87 in these people who had an infarct, and in these patients over here, the LDL, as you can see, was 109. And so patients having myocardial infarction, the LDL is many times, not just like our patient this morning at Baylor, is not as revealing as we like to think. Well, what do the experts think? And I'm sure some of you in the room are on this big committee that opined regarding inflammatory biomarkers in preventive cardiology a few years ago. And I just put up these evidence tables for you to look at for a second. In the initial clinical assessment, as you can see, CRP, Lp(PLA2), ApoB, LDL particle number, and lipoprotein little a, and then HDL and LDL subfractions, that in general the advanced markers start to get some suggestion on use when there's more than low risk present, particularly along the lines of a family history or recurrent events when we're doing the initial assessment. Notice that the subfractions weren't recommended by anybody at that time, but there are recommendations across the board here for these advanced measures. The on-treatment management across the board here, Lp(PLA2) actually did not get any recommendations, but there were some for CRP, ApoB, and LDL particle, and Lp(a). So it's still very much a mixed world of opinions out there on when we should use these factors. I can tell you in Baylor, where our CEO is a guy named Joel Allison, and he's kind of betting the farm on this concept that personalization of medicine is going to lead to improved outcomes. And our major tools for personalization is going to be advanced risk assessment, largely driven by laboratory and advanced imaging and other measures. That's really going to drive that it's not going to be one therapy fits all forever in medicine. If the cancer doctors are showing us that personalization is probably the way to go, and we're going to see that, I think he's right on this. He's just a business guy, but I think he's right that in fact these tools are up here on the board here that we can't agree on whether or not we should use them, but in fact these are the tools that help personalize things for us, because we will have therapies that will match these personalized profiles, in my view, in the future, and that's going to lead to improved outcomes. So to finish and conclude, Lp(PLA2) plays a role in the initiation and progression of atherosclerosis. The epidemiologic evidence is strong for added prognostication of cardiovascular events with this test. The plaque activity test, which is currently indicated for primary prevention of coronary heart disease, while the plaque ELISA test, the older concentration test, its indication is for both for CHD and for ischemic stroke, both in primary and secondary prevention. And we anticipate the new activity test will also win those indications. Anti-atherosclerotic lipid-lowering agents do reduce the concentration of this enzyme. However, there's insufficient evidence to use the test results to select drugs or titrate doses at this time, and I think that's a fair conclusion.